Hello, everybody. This is Dr. Scott Worden, the TOS guy. We're live streaming from beautiful downtown Sunnyvale, California. I hope everybody is doing great out there. Today, we have another episode of 5 TOS questions. I'm going to pick some very commonly asked questions that we hear and try to answer them in a brief format. So it'll be a roller coaster up and down. I hope that's exciting for everybody. Let's start. Number 1, which doctors or specialists treat TOS? This is fascinating to me because I'm also a big fan of medical history. No one has really taken ownership of neurogenic thoracic outlet syndrome. There are doctors who are surgeons, there are doctors who are non-surgeons who diagnose and treat the disease. The vascular forms of TOS have long been treated by vascular surgeons, and that would be arterial TOS, which makes up 1% of all TOS cases, or venous TOS, which makes up 5% or less of all TOS cases. So they know the territory and the country and the anatomy if they go in. But the treatment of neurogenic TOS, the most common form by far, 95 to some people say 98% of all TOS is neurogenic TOS. Well, the vascular surgeons know the area, but they don't often deal with nerves, so they have different approaches. So we get people like peripheral nerve surgeons who train in plastic surgery and then specialize in these small, medium, large, even tiny branches of nerves that cause people pain and other symptoms. And they approach it differently than vascular surgeons do. We have some neurologists who treat it, although the old controversy from the 1980s and early 1990s about the existence of TOS was started by neurologists. So I would say somewhat less neurologists deal with this. We get physiatrists, now more sports medicine docs, because we're finally recognizing TOS in a lot of athletes. And these are young people who we want to help more. So if you want to know which specialist treats TOS, you can't go to a specific specialty. You can't go to a specific institution unless they've got a dedicated TOS team. Places like Massachusetts General Hospital with Dr. Dean Donahue, or in Philadelphia, University of Penn with Dr. Darren Schneider, or other universities like Northwestern around the country, UCSF, UCLA with Dr. Hugh Gelibert. But what we can do is if you reach out to us through tosmri.com, we can help connect you with the right specialist for you. This may be a specialist who's geographically close, or it may be one who has experience with your particular type of TOS. Before I go on to the next question, I want to remind everybody that if you're watching this on YouTube, please help us out. Hit the like button. Also subscribe and hit that little bell so you'll hear every time we have a new episode. We want to grow this channel and grow awareness that we're spreading to everybody, as well as knowledge about TOS, and you can help us. The algorithm will get your happiness. It'll shift it onto our channel. All right, hit the like button. All right, can sleeping in a certain position make TOS worse? Now, this isn't a common question, but we're finding it's starting to show up more now. Many of our TOS patients have to sleep in very specific positions to avoid symptoms. If we go back to the 1910s, there was a doc by the name of Thomas Wingate Todd, I believe, Todd. And he was starting to get the idea that some of these patients with this strange neurovascular compression syndrome would get it by having their arms in unusual positions. So in 1911, he started sleeping with one arm over his head, and he got symptoms eventually. It took 8 years to develop symptoms, which were probably due to injury to the artery, the subclavian artery, and he would get ulcerations and small blood clots in the tips of his fingers. Interestingly, in 1945, I think it was a captain or corporal, he was a captain in the U.S. Army named Irving S. Wright, W-R-I-G-H-T, if you want to look him up. In 1945, he referred back to this because he had found that there was a positional change in many patients that caused these symptoms. But as you probably all know, if you've listened to our channel, there are many underlying anatomic causes of TOS and many different postures in different people. That explains why there are so many tests like the Wright test or the Adson's test or the upper limb neural tension test that would be positive in some patients and not in others. So Wright, or W-R-I-G-H-T, took 150 patients without symptoms, and he did various forms of these different tests, pressing down on the shoulders, moving the arm away from the body a certain distance and a certain angle. And it turns out he could reproduce some arterial compression in all of the patients with the exception of 11. So out of 150 patients, 139 had some kind of reproducible arterial compression or, I believe, neurogenic symptoms. And he was the first person to use the syndrome, what's called pectoralis minor syndrome. He actually used that term. I had previously thought 1950 was the earliest with a guy named Jerry Lord, but now, fortunately, I found this earlier paper. I think he's the first one to use that term. And he also called it subcoracoid, which is a term I use in my reports when you get one of my MRIs. I think this is a very important spot. It's often called pectoralis minor syndrome and thought to be a spot where the nerves get compressed behind the pectoralis minor muscle. But in fact, even the first people who wrote about that, like Dick Sanders in Colorado, they took the idea from Wright in 1945, and he did not say that. He thought, as I do, that this is tension as the neurovascular bundle passes under the coracoid process to reach the arm. So yes, sleeping in certain positions can expose you more to symptoms, and we believe it's due to either the nerves being entrapped in the scalene triangle or this bowstringing or stretching under the coracoid process in the pectoralis minor, retropectoralis space, actually. Question number 3, is TOS more common in men or in women? All the literature that I know of and my personal experience says women are the unfortunate losers in this situation, that they have more common neurogenic TOS than do men. And we believe that's for a number of reasons. The architecture of the chest is different in men and in women. Obviously, men on average tend to be broader, wider side to side with longer clavicles, and their chest is deeper anterior to posterior. To accomplish this deeper measurement from front to back, their ribs are at a different angle. They are more flattened out and moved forward than women, whose ribs tend to be angled more and giving them a narrow antero-posterior or front to back diameter of the chest. In addition, over your life, the shoulder girdle starts very high when you're young, and it gradually descends through the course of your life into adulthood. This was studied by Stopford and Telford, as well as some papers by Todd, who I had mentioned in the 1910s. So the combination of those findings means that there's a certain sweet spot where the shoulders are descending just enough and the clavicles are just the right length and the ribs are angled just right. This would be in the woman's 20s to 40, let's say. I'd say 25 to 40 or 25 to 45 is the time in life where all these things overlap and create the narrowest spaces, limiting the passageway of the brachial plexus and therefore increasing the risk of neurogenic TOS. And because women have these different characteristics in general, I believe, without really much measurement or proof, that's the reason why they're much more commonly getting neurogenic TOS than men do. Nonetheless, there's plenty of data out there that says that women get this much more frequently, probably 75% of cases to 80% of cases are women rather than men. Let's go to question number 4. Can stress and anxiety cause a TOS flare? And the answer is yes. We hear this all the time from our patients. The central nervous system is flexible and it's plastic throughout your life. Patients who have pain often find that they can control the pain with modalities like meditation in conjunction with pain medications. Good sleep will help you feel less pain. The central nervous system will send out signals to modulate the amount of pain coming back into the central nervous system. But when you get a chronic disease, patients with chronic arthritis or something like neurogenic TOS that isn't treated, over time their central nervous system starts to change and it starts to incorporate that pain and sort of start to glue it in place, which is why we want to address this before it gets from acute pain to chronic pain. So some people have used psychotropic drugs like amitriptyline, an antidepressant, which can help stimulate that part of the central nervous system that goes out and modulates the pain at the receptors. So patients who are anxious, who have an altered central nervous system because of outside stressors or internally abnormal response to stressors, they tend to have problems with all kinds of chronic pain, not just with thoracic outlet syndrome. And besides that, some patients who have neurogenic thoracic outlet syndrome, when they go through certain tests, like they go to see their doc and the doc does an upper limb neural tension test or a RUSE test, that can create a flare up as well. And then some other patients, some who get Botox injections into the scalene muscles, for example, they can get a temporary flare up before the Botox kicks in. Question number 5, are there specific exercises I should avoid? We've had a guest on several times, Steve Talikowski, a doctor of physical therapy, and he's got decades of experience with thoracic outlet syndrome using the edge low technique as he's modified it, and he's seen many, many, many patients. And his coaching from the beginning almost always involves relaxing the central nervous system, as we just discussed, that might help, and not strengthening the muscles, which some schools of thought for neurogenic TOS physical therapy have emphasized. But in his experience, he wants to relax those muscles. He wants to reshape the posture, which has been altered by abnormal dynamics, muscles front and back being out of balance. And you may have read, if you've read much about neurogenic TOS, that patients with TOS often assume an abnormal posture where their head forward, their shoulders rolled forward, their back hunched. And this is usually thought to be a protective mechanism to relax the pressure on the nerves as much as possible, even when they're compressed. But that puts you in a position where the muscles assume new postures and tend to stabilize in those postures. That's why Steve's approach will emphasize relaxation of muscles all around the neck, the muscles of breathing, which the scalenes do contribute to. They are secondary or accessory muscles of breathing. And then posture, because as your muscle balance changes, as you tilt your head forward or your shoulders forward, the rest of your spine has to compensate to keep you in an upright position. So in general, a person like that, Steve Talikowski, is a better physical therapist than me. And clearly there are programs that minimize the amount of muscle use. I can also say that that would leave out certain things, typical training things like weightlifting, exercises like overhead swimming or tennis playing or rock climbing. So those would have to be tempered in the first stages of treatment of thoracic outlet syndrome. So that's our 5 questions for today, but I have a bonus question that we decided we would ask. Is it safe to lift weights if I have TOS? And this is part of what we talked about. I would say there's a couple of effects. One is you don't want to train your muscles in an abnormal posture. So if you've already gotten this abnormal posture from the pain of TOS, you don't want to fix that in place. You want to let the muscles relax and retrain rather than just pushing yourself through this. And having gone to a personal trainer, I know we try to push ourselves through the pain, because if you're trying to make progress, lifting weights, getting stronger, rebuilding your balance, then you tend to try to push your limits a little bit, just increase the weight a little each week. And so that can be bad when you already have postural problems or shoulder position problems. So I would advise against weightlifting if you have TOS until you have control of the disease and your posture, both your shoulder posture, your head and neck posture, and your standing posture are all aligned as per your caregiver. So that's our 5 questions for today that we've answered, and a 6th one as well. And we're welcome to answer any questions from the audience if we have them. Hi, Dr. Worden. Thanks for another talk and an opportunity to ask questions. It's good to see you again, and we always appreciate being able to help people out there and raise awareness. I hope you're doing that too. We ask folks sometimes to go on social media and help spread the word. We're not selfish. Most of the patients we talk to, we send out to specialists, referring TOS specialists. So we want to help the whole community grow so people don't have to be in pain in the future. Can long-term reduced blood flow from venous TOS eventually affect the bones? I've never been asked that question before. So the topic of our talk today is 5 common TOS questions, and you threw in an uncommon question. All right. Venous TOS is, by definition, the classic definition, a blood clot appearing in the subclavian or axillary veins that come from the arms back to the chest. Those blood clots are usually easily found on ultrasound in the emergency room, because patients will often show up with a swollen arm. It may be a dusky purple or bluish color because of the deoxygenation. and the blood flow from the veins, which is low pressure, cannot get back from the arm to the chest. So they'll have swelling and tightness and pain. And this is a situation which is a surgical urgency. I wouldn't say it's an emergency, but it's usually treated fairly urgently. Ultrasound is the standard of diagnosis in the ER or in an urgent care center. It's usually easy to find not only the blood clot itself, but abnormal blood flow in those veins that return from the arms back to the chest. So even if you can't see the blood clot, when you move the patient's arms, you can see the blood flow doesn't behave the way it should on the other side or the normal side. And then treatments are usually blood thinners to stop the clot from growing. Some people will actually use tiny little catheters and remove the blood clot. Some people will use TPA, a blood clot dissolver, that actually dissolves it faster than the body would. And after that is acutely treated, the patient will be left on blood thinners, and then surgery will be planned, possibly a stent, a metal cage that keeps the vessel open, or partial removal of the anterior part of the first rib. It's done different places in different institutions, and they all have their different methods for what they believe is the best approach. But what I would say is in that situation, a stent by itself isn't enough because if the vein was compressed by something abnormal in the motion, that stent will be compressed as well. Now, will it affect the bones? To the best of my knowledge, directly, a blood clot there won't affect the bones. Number one, it's not left there for long. If you show up with the symptoms I mentioned to urgent care or the emergency room, they're going to treat it and remove the clot and restore normal blood flow. And that will be the goal all along the process. They may do a venogram to see if there's a residual scar or narrowing or stenosis or a web. All those mean the same thing, that the vein is too narrow because it's been injured, but that will be treated with a balloon, just like they do in arteries of the heart. And the goal is for the surgeons to keep that blood vessel open. So it's not really a long-term blood clot that's in place. And I don't know of a mechanism where it would cause overall loss of bone density or any other problem like that. It doesn't increase the risk of fractures. So I would have to say, no, I don't think there's an association between venous TOS and bone abnormalities. And thanks for the question. Hi, could you briefly explain how the extra scalene muscle causes TOS? And thank you, the scalenus minimus. Actually, through history, I've found 26 or 28 different names people have used for thoracic outlet syndrome, and the anterior scalene syndrome, or the scalenus anterior was one of those. The scalenus minimus is an extra muscle that forms in the scalene triangle as a result of your particular embryogenesis. It doesn't occur in everybody. There are wildly different guesses as to how common it is. I'd say, from my personal experience and from the literature, 5%, maybe 10% of people have a scalene minimus muscle. There is the scalene anterior muscle. Behind that muscle is the scalene triangle, which contains fat, the subclavian artery, and the brachial plexus, but not the vein. Behind that is the middle scalene muscle, and behind that is a smaller, more variable posterior scalene muscle. The scalene minimus muscle is a kind of a residua of those muscles developing and separating over embryogenesis, and it's a band of muscle that can be very small to moderate in size, and it comes from the cervical spine and heads down to usually the top of the lung. And so the scalene triangle, where there's fat, brachial plexus, and artery, gets split in two by this extra muscle. And it can often be tight, like a fibrous band. So it's splitting that triangle into two parts, which already narrows it. And then you can have the nerves rubbing up against it chronically. So it can be a potential cause of neurogenic thoracic outlet syndrome. And it's important for me, when I read a study, to always identify whether a variant muscle like that is present. I can tell you in many patients, including the last one I read this morning, there are variations in these scalene muscles. I believe what happens is that the muscles form as a sheet of muscle, and as the nerves of the brachial plexus grow in the embryo, they penetrate that sheet, separating those muscles out into anterior and middle scalene muscles in particular. But it's a messy process, apparently, because there are so many variations where the nerves go through the muscles instead of through the scalene triangle, or where they leave a scalene minimus in place. Now, people can have a scalene minimus without symptoms. This is just like elsewhere in the body. We have all spots in the body where there's a bone spur or a fibrous band or an extra muscle. And some people with those develop nerve entrapment syndromes over time. There's something called an avian spur. If you take the upper arm bone and go to the distal part of it near the elbow, there's this bone spur. It's totally benign. It looks like a bird beak or a bird claw, and it's called an avian spur. And that can press on the median nerve. And if you wait long enough and you take the right kind of activities, it can create symptoms. But in many people, it doesn't. So I view it as a predisposition. If we have a patient with the right symptoms and these anomalous muscles, then they can be treated. And thank you for a good question. What percentage of patients in your experience have both TOS and bulging or herniated discs in the neck? That is a very good question. One of the differential diagnoses for patients who show up with possible neurogenic TOS is spine disease. If they have the right kind of herniated disc or disc bulge or degenerative change of the neck, then it can mimic thoracic outlet syndrome. It's relatively uncommon because the pattern of symptoms is usually bilateral in TOS, and it's hard to get the same bilateral symptoms from cervical spine disease, although it does happen. And the pattern of distribution in TOS is very distinctive, almost always involves the ulnar nerve distribution, even if it's involving more than the ulnar nerve. Also, one of the big things is that, as I mentioned with the previous question about women versus men and the ratio of the two genders getting TOS, the age of people who get TOS is like 25 to 40 or 25 to 45. That's most common. And people in that age range tend not to have herniated discs or degenerative changes of the spine nearly as often as someone like I, who's I'm a little older than 25, might get. So the degenerative changes occur with time and aging in all of us. Or if you're really working heavy duty jobs, like you're operating heavy machinery or you're digging ditches for your whole life, you're going to get degenerative changes earlier just from overuse. There are some tests clinically. People will do a Sperling test, Spurling, where I believe the clinician will press down on the top of a patient's head and see if they can reproduce the symptoms. And a positive Sperling test would indicate that the neural foramina, the side holes of the spine, are narrow on one side or the other. And then, of course, we've discussed in the past clinical tests to try to diagnose and distinguish neurogenic TOS, which are different than a Sperling test. MRI shows degenerative changes and herniated discs and which nerves they're pressing on very well. So in our study, the Nia Vista study, we always include the cervical spine just to rule out that unlikely situation. Again, most commonly, people who are younger get TOS, people who are older get degenerative things in the spine. And you can use some clinical tests to separate them, and MRI is great at separating them. So thank you for that good question. I want to remind people, please hit the like button if you're on YouTube. Help us out, help us spread the word. And you can hit the subscribe button and the little bell so you'll be reminded every time we have a new show coming up, a new live stream. Judy D'Amarillo, what I felt is the more I do stretches, the more I have pain. Is that normal? First of all, I have to say we can't really answer specific medical questions for individual patients here. Please come to our website. On the TOS page, there's a big contact us button, and we're glad to chat with you and help steer you the right way. Also, it's hard to tell from the way your question is worded what kind of stretches and what kind of pain. The evaluation of patients with TOS almost always involves certain positions of the arms and the neck and head. So if you're doing stretches that involve the neck, the head, the upper extremities, and you're getting aggravation or initiation of pain, numbness, tingling, other abnormal sensations with your arms in front of you or overhead or out to the side, that is a suggestion of neurogenic TOS. And then I would ask your personal doctor, or we can help you find a TOS specialist. I would let them do the more advanced clinical tests and try to start narrowing that down. Thank you. Leanne Williamy, and forgive me if I'm not pronouncing the handles correctly. I have had a normal-ish EMG. Would an MRA or MRV help diagnose? And that's a good question because it brings up a lot of different little topics. So I'm going to keep them a little bit shorter for each one. An EMG is part of a test called electrophysiologic study. It's where people study the velocity and the waveforms of the nerve transmissions. And they also study with the EMG part of it, how the muscles react when they're stimulated or touched. The muscles and nerves have a complex relationship, and if you damage the nerve, the muscles will eventually behave abnormally. They'll give off spontaneous electrical signals they shouldn't. So these tests are important, but they don't show up early in the course of nerve disease. So some people have said that you need to have 80% of a nerve damaged before these electrophysiologic studies will show up as abnormal. Now, in conjunction with neurogenic TOS, what we know is that patients often get sensory symptoms first. The sensory nerves tend to be at the outside of this nerve, the physical nerve you could see on a microscopic level. The smaller peripheral nerve fibers, individual nerve cells, tend not to have a myelin coat, a special insulation. They tend to be smaller diameter. They tend to be at the periphery of the nerve physically. And the motor nerves that control the muscles tend to be central. They're larger. They have, in many cases, a myelin or insulating coat. And so damaging the motor nerves takes longer than damaging the peripheral nerves. Patients with neurogenic TOS often have symptoms that are intermittent at first, and they get worse over time, and they tend to become continuous over time. But they tend to be nerve symptoms like allodynia, where something soft actually feels painful, or temperature sensations, hot or cold, or color changes regulated by the nerves, or tingling, or anesthesia where they can't feel certain things. Many different nerve sensations, but it's sensory things that occur first. If you wait long enough with neurogenic TOS, the muscles of the hand will start to get small and atrophied and weak. And that's the point where the EMG is more likely to be positive. I just read a paper on this from, I think it was 15-year-old paper that said that the patients who had positive electrophysiologic studies went to surgery and had a worse outcome than the patients that had a normal EMG/electrophysiologic study. Now, you also asked, would an MRA or an MRV help the diagnosis? I want to stress that compression of the veins and compression of the arteries does not confirm compression of the nerves. It may be present, both arteries and veins, either one can be compressed and the nerves are fine, or you could have the nerves being severely compressed and the arteries and the veins are just fine. So in the old days, an Adson's test, which relies on blood flow, was performed because Adson didn't have MRIs or CAT scans or ultrasounds or anything like that. So 1920s. If you see a doc and the doc thinks you might have TOS, the neurogenic type of TOS, and they get ultrasound of the veins or the arteries, there are two pitfalls. One is maybe they're not done with your arms in different positions. So that gives us no information about your arms being up. Number two, the doc ordering it may not understand that these studies can be completely normal and you can still have neurogenic TOS. I'll repeat that, and I apologize for the dog barking. You could have normal ultrasound of the arteries and veins and still have neurogenic TOS. So your question involves both electrophysiologic studies, which can be completely negative and often are in patients with neurogenic TOS, and MRA, study of the arteries, and MRV, study of the veins, may be completely normal, but you could still have neurogenic TOS. Our study, the Nia Vista study, includes looking at the nerves, includes moving the arms, looking at where there's compression of the nerves and the multiple tunnels we know of. We look at the different positions of the shoulder blades and the collarbones and the first ribs with the arms down, the arms up. We look at the arteries, we look at the veins, we look at everything so nothing is left out. We look at the cervical spine. So our study is very comprehensive. We've got it engineered so it takes about 45 minutes in the scanner. And we as I get asked these questions, I'm happy and proud that we cover all of these things, at least as we know right now, that could be causing or contributing to neurogenic TOS. Thank you for the question. Would there be any benefit to a dynamic EMG? That is super. I don't know much in the literature. What I can tell you is there are very few papers where they've done actually the other part of the electrophysiologic study, the nerve conduction velocity. They've done it during surgery. So I think at LSU, there was a guy, I'm blanking on his name, Gilad, and I think he had a small study where they actually measured abnormal velocity in the nerves in the thoracic outlet while they were doing the surgery. Now, you can't get to these nerves, they're very deep in the neck. You're not going to put a needle in there or put a sensor, put a little pad over it to simulate to send a shock through the nerves. You just can't separate those nerves out. They're too deep and too complex. But clearly at surgery, there is some difference in these. And oftentimes when those are abnormal, those patients have hand muscle atrophy, meaning it's an advanced case. And I'll say one more thing about it. When you do have motor nerve involvement and muscle atrophy, it's a lot harder to recover your function fully. So as doctors, we want to get to these before we get an abnormal electrophysiologic study, before we get hand muscle atrophy. Okay. And in the past, some doctors have waited and said, you don't have neurogenic TOS until you have the hand muscle atrophy. That's just waiting too long. Okay. Good question. Oh, and by the way, I don't know of a test that dynamically has looked at those and measured the nerve conduction velocities at the same time for that last question. Hey, success story here. Yes, success story. I had really bad TOS and could not get on the computer. Couldn't do a lot of things without pain, but now I'm in great spot through diaphragmatic breathing for over a year. All right, Scott, I love your first name. It's the best first name, isn't it? That's why they say Great Scott. That's how I tease my kids. They hate it. We're really glad to hear any success story because TOS can definitely be conquered if it's diagnosed and handled correctly. I want to ask you if you learned the diaphragmatic breathing through the Edgelow method. As I mentioned, Steve Talikowski in our area uses the Edgelow method, and I know he focuses a lot on breathing. If you want to share details, we're happy to hear them. Good. I'm glad you're doing better. Thanks, Scott. All right. If we don't have any other questions, I want to thank everybody for attending. We really appreciate the support. Again, we'll ask you guys to share the word. We're here to help. We help a lot of people at no cost. We spend our time because we believe we can steer people to the right resources and help them get better. Scott told us more. Steve helped heal me. Yeah, good for Steve. He's a great guy. I met with him multiple times over the course of improving. But it's great. I mean, Steve he's just the nicest man in the world. He cares about his patients. He's so experienced. When I had a different musculoskeletal problem, he was the first person I went to see. And if anybody wants to be introduced to him, if they have TOS and they're interested in the physical therapy from a very experienced guy, reach out to us. We're glad to connect you, and you'll be happy you did. All right. Herb, thanks for everything. We are going to have a very interesting conversation with Dr. Sam Ferris. He's in the Mayo Clinic in Jacksonville, Florida. That is scheduled for July 7th. He has a really great and really organized program for TOS patients that we're happy to discuss with him. And we'll probably have some more talks before then. You don't have to wait till July 7th. All right. You can follow us on Instagram, and we share a lot of our stuff there. We'll have to spread out and do some Twitter or something soon, but we'll let you know as we get that shaped up. So for now, this is Dr. Scott Worden, the TOS guy in beautiful Sunnyvale, California. Here's the best to everybody. Reach out to us for any help. Click the like button and subscribe, and we'll see you next time.